Greetings and welcome to AWHONN Insights, the home for candid nursing conversations. Last year in Phoenix, we collaborated with our partners and changemakers from the Collaborative for Alcohol-Free Pregnancy to bring you a podcast episode focused on preventing fetal alcohol spectrum disorder. This year in Orlando, we're continuing the conversation and discussing alcohol and polysubstance use across the lifespan. Our guests are Faith Osier-Green, a research professional and project manager at the University of Alaska Anchorage Center for Behavioral Health Research and Services. She specializes in community-led research projects around healthcare access in rural Alaska. And Katie Davis, also a research professional at the University of Alaska Anchorage Center for Behavioral Health Research and Services. Her focus is on project evaluation and health communication. I'm your host, Bria Anopise, and I'm joined by co-host Dr. Cassandra Grecci, AWHONN Senior Manager of Women's Health Programs, and Shannon Francois, a clinical nurse educator and labor and delivery nurse. Cass and Shannon, I'm turning the podcast over to you.
Thank you, Bria, and welcome, Faith and Katie. Since our last conversation focused on your FASD research and implications for nursing practice, how has your research evolved, and what prompted you all to expand your studies to alcohol and polysubstance use across the entire lifespan?
Thanks, Cass, and thanks for having me today. So currently our research is focused on evaluating trainings and learning methods, and specifically getting feedback from in-practice nurses on FASD-related care. The alcohol and polysubstance use conversation was a natural development from our discussions about implementing universal screening in the prevention of FASDs. And the large majority of U.S. adults, because they have reported consuming alcohol in the last year, about 80% for women, and many folks who use any substance, whether that be alcohol, cannabis, tobacco, or other drugs, also report the use of another substance. So discussing substance use as a singular concern wasn't really accurately capturing all of the challenges that have to do with polysubstance use. So broadening the discussion to polysubstance use allows for that nuance of what evidence shows as the reality of substance use for adults. This is primarily within the context of FASD prevention, whereas our use of the lifespan framework has to do more with the treatment and recognition of FASDs throughout the entirety of a person's life and their healthcare experience. So often the discussion focuses on prevention, which is extremely important. However, with FASDs being as prevalent as they are, 1 in 20 school-aged children, it's important to also spread awareness about identifying the strengths and challenges experienced by these individuals within the healthcare system across the entirety of their life.
Thanks, Faith. So, recent data from births covered by Medicaid between 2016 and 2020 shows an overall 18% decrease in the national rate of neonatal abstinence syndrome. However, during that same period, the national rate of substance exposure at birth increased by 3.6%. This trend suggests that while opioid-related neonatal abstinence syndrome may be declining, more pregnant individuals may be using other substances not typically associated with neonatal abstinence syndrome. What does the current research tell us about the substances most commonly being used during pregnancy, and what do we know so far about their specific effects on fetal development?
Thanks, Shannon. So while opioids are still a big issue in the U.S., the rate of prescription opioid use has gone down significantly. Doctors are not using these prescriptions as easily, and they are much less available on the market. And the potential dangers of opioid use and addiction are much more widely known. That being said, rates of use of alcohol and cannabis during pregnancy have ticked up over the last 20 years. So starting with alcohol, I'm just going to throw some stats at you. So from the CDC, about nearly 14% or 1 in 7 pregnant women reported currently drinking alcohol, and about 5% reported binge drinking in the past 30 days. So pregnant women who experienced frequent mental distress and those who did not have a standard or usual healthcare provider reported much more likely to report alcohol use. Both current alcohol use and binge drinking among pregnant women in the U.S. has increased slightly from 2011 to 2018, which are the most recent stats we have for that. And current drinking rates increased from 9.2% to 11.13% over that same time period. Although it's been proven that alcohol use during pregnancy is associated with an increased risk of things like miscarriage, preterm birth, stillbirth, and sudden infant death syndrome, alcohol use during pregnancy is still happening and can range from a lifelong behavioral, intellectual, and physical disabilities known as the fetal alcohol spectrum disorders, or FASDs. As far as cannabis goes, a recent study suggests that cannabis use more than doubled among pregnant women in the United States from 2010 to 2017. While cannabis use was more common during the first trimester than during the second and third, it's still important to note that this increase has been substantial. And past month cannabis use increased from 3.4% to 7% amongst pregnant women overall, and even more during the first trimester. The study included information of about 500,000 women of childbearing age who participated in the National Survey on Drug Use and Health. Cannabis use in pregnancy is a challenging topic and may have increased generally because of its increased availability and higher rate of use in the general population. Personally, I live in Alaska, which is a state where cannabis is recreationally legal, but this varies from state to state, as you know. Even medically, cannabis can be prescribed for the treatment of things like chronic pain, nausea, and other conditions. However, there is a lot of misinformation suggesting that it is safe to use while pregnant and can help with things like morning sickness, which is unequivocally not true and proven across multiple states and multiple studies. So while the research of the effects on cannabis in pregnancy and childbirth is limited, it is known to possibly lead to birth defects, low birth weight, premature birth, smaller head circumference for baby, and contribute to the rate of SIDS.
Thanks, Faith. In South Florida, the Hanley Center, one of the region's larger treatment facilities, launched Casa Flores, which is a comprehensive program designed to support pregnant people struggling with substance use disorders. This 3-phase residential program provides care throughout pregnancy and continues up to 9 months postpartum. In addition to stabilization and trauma recovery, Casa Flores helps participants build parenting skills, prevent relapse, and access resources for housing and employment. What are your thoughts on this type of approach for treating pregnant and postpartum patients struggling with alcohol and substance use disorders? And how could this impact long-term outcomes for the patient and their baby?
So first of all, I think that this program sounds really amazing and would highlight that about this approach that it's comprehensive. So providing care and stabilization support is the best way to improve outcomes for individuals with substance use disorders, and the challenges are only compounded when you are pregnant. I also love that this program continues through the perinatal period, that 9 months postpartum, because that is a really challenging time for women post-birth and is especially precarious when it comes to relapse. Building parenting skills and providing support for housing and employment can create that stability necessary for individuals to succeed and prevent relapsing. So I think a program like this would allow these women to have a supportive community, which we know is vital to success in sobriety.
Yes, I definitely agree that this program sounds really amazing for individuals struggling with substance use disorder. More broadly here in Florida, substance and alcohol use disorders among adults aged 18 to 25 are on the rise, with substance use disorder increasing from 27 to 28.5%, and alcohol use disorder rising from 13.9 to 15% between 2021 and 2023. Despite the increase, only about 4% of those who needed treatment actually received it, highlighting the significant gap between need and access to care for young adults in the state. What do you see as the main barriers to accessing care for this population across the country, and what can be done to close this gap?
Yeah, so I would assume that part of this issue is lack of screening, albeit that's a bit unclear from the data. However, from some additional reading, we did find that Florida has a really high rate of uninsured individuals, especially amongst this demographic, about 18.5%, which provides a significant barrier to treatment. So I would say first, an important part of bridging this gap would be providing full coverage health insurance for this demographic. Furthermore, substance use treatment is often expensive or not fully covered by insurance, so making sure that insurance coverage is comprehensive. Also, individuals with substance use disorder may not know their treatment options, and they may think that their options are either rehab or immediately getting sober and going cold turkey, not realizing there are other options and methodologies available to them, such as outpatient centers or medication-assisted treatment. There's also a lot of stigma associated with substance use, which we know can be a significant barrier to pursuing treatment in the first place. So I would say a big part of bridging that gap, whether that's about understanding treatment options or understanding the stigma associated, would be having conversations like this and having providers and nurses feel more comfortable having safe conversations with their patients about substance use.
Now, building on your previous research contributions, what does the current evidence say about the most effective screening tools and assessment strategies for identifying alcohol and polysubstance use across different population and care settings?
So screening, brief intervention, and referral to treatment with a validated alcohol or substance screening tool is the most effective way to identify alcohol and substance use issues. And there are several tools that can be used for screening, but the AUDIT, which is the Alcohol Use Disorders Identification Test, administered via electronic screening, has been found to be a very effective way at accurately screening for alcohol misuse. And it is validated with populations 12 and older. And there are also other validated screening tools if you're looking to specifically screen for other substances or that polysubstance use, such as the DAST, which is the drug abuse screening test, and that can be used to assess use of things like cannabis, solvents, tranquilizers, barbiturates, cocaine, stimulants, hallucinogens, or narcotics. But the DAST does specifically exclude alcohol. So those would be the two tools that I would like to point out.
Overall, your research has explored both prenatal alcohol exposure and current substance use. What does the evidence suggest about how nurses should adapt their approaches when working with patients who have both current substance use disorder and a history of prenatal alcohol exposure or fetal alcohol spectrum disorder?
Absolutely. Currently, there's very little research done about the crossover of the lived experience of individuals with FASD who also have substance use disorder. So I'm going to answer this question first from the perspective of addressing substance use disorders as a whole, because best practices are best practices, regardless of the population most of the time. So you know that Ted Lasso quote that says, "Be curious, not judgmental"? I think that is vital in all discussions about substance use. So first, never assume that someone does or does not have a substance use disorder until you know the facts and have screened them using an evidence-based screening tool like one of the ones that Katie just mentioned. If it has been established that someone is experiencing a substance use disorder, it is extremely important to be patient-centered in your language and assessment. Ask questions about a patient's interest in changing their behavior, ask about why they're using, and what their concerns are about their own substance use. Obviously, nurses are experts in patient care, but only patients are experts in their own life, and the good intentions of practitioners can often get in the way of good practice. So once you can assess someone's motivations and willingness to change, I would encourage you to use the strengths-based language to co-create a plan using incremental change markers. If someone isn't interested in quitting cold turkey, giving them a plan to stop using is a waste of everyone's time and resources. So meet them where they are at and make sure you are able to make a plan that can work for them. Addressing the second part of your question, when working with an individual who's experiencing an FASD, ask them what works for them and what doesn't. Individuals with lived experience on our collaborative team have discussed their need for things like appointment reminders and to have written care plans that review everything discussed in the appointment. So speak to them like experts in their care, because they are at the very least will know what doesn't work for them. And again, using shared decision-making tools to ensure patient buy-in and employing patient-centered language throughout the entire process is extremely important. The reason I encourage these practices is I want nurses to establish themselves as a safe point in the health systems for individuals with FASDs. So if you have to establish rapport with someone and respect their autonomy and decision-making throughout the process, they're much more likely to come to you if and when they're ready to address their substance use disorder.
Thank you. Can you further discuss what you feel is important for nurses to consider when supporting individuals with an FASD diagnosis?
So FASDs are a type of neurodiversity. No two people with FASDs are affected in the same way. And there is immense variability in the capability of those with FASDs and in their experiences of life. So like Faith just said, nurses may be experts in healthcare, but only patients are the experts in their own life experiences. So ask the individual whether they are neurotypical, experiencing an FASD, or neurodiverse in any other way, what the best way to communicate with them is, and what resources are helpful, and how you can best work with them. Some individuals may prefer written resources over verbal communications. Others may need persistent appointment reminders. It's all variable and comes down to the individual. And generally speaking, using strength-based care and methods and addressing individual autonomy throughout the process is extremely important. And don't make assumptions about their life experience or expectations.
Additionally, your previous research highlighted stigma reduction around FASD. What does current research reveal about how stigma manifests differently for individuals with substance use disorder at various life stages? And what evidence-based strategies can inform nursing practice to address these attitudes?
Stigma is an extremely important topic when discussing FASDs and substance use in general, but it's also very nuanced and complicated in a way that comes up for individuals in the care system. At its bare bones, stigma comes from shame, and you don't need to be in therapy to know that it is a deep-seated human emotion that is challenging to address. So I'm going to look at this through 3 different life stages. So let's look first at the pregnancy and birth section, right? So stigma shows up here because individuals who are pregnant and may have a substance-exposed pregnancy may not want to disclose their substance use. They may not know that they were pregnant or didn't realize the consequences of using substances, and they may be ashamed or afraid to tell their care providers for fear of judgment or fear of the very real legal consequences that may result. This can lead to a lack of early intervention and patient education. And to address this, I recommend nurses and care teams come up with scripted language that is non-judgmental and realistically addresses that many pregnancies are unintended. Many individuals did not know that they are pregnant before late into the first trimesters. And most adults use at least one substance. So speak openly and honestly with patients to address their concerns and come from a place of non-judgment. For teens and young adults, stigma can manifest more in the form of concealment. They may be experimenting or not, but either way, fear of the judgment that comes from their peers and fear of the consequences from their parents or guardians, so they are in the dark. Nurses and other care providers can do a few things here. First, talk to adolescent patients with their parent or guardian out of the room if this is comfortable and appropriate. Give them a chance to talk without their guardian there, and maybe you will learn more. Second, normalize experimentation with substances without encouraging it and affirm their privacy and disclosure in care. Lastly, talk about harm reduction techniques and give them resources so you can establish yourself as a trusted point of contact. And hopefully in the future, if they do have questions, they feel comfortable enough to talk to you. So for middle-aged folks and older adults, stigma can manifest in a variety of ways, whether that's concealing their use from others, refusing to seek treatment, or a general sense of denial. Nurses and care providers can attempt to address this by conducting universal screening to identify high-risk use, and for individuals who may have a disorder, explaining the variety of care options that are available to them. Again, during this process, using patient-centered care and non-judgmental language is essential. So if individuals are experiencing stigma and shame that seems beyond the scope of your practice, I would always encourage them to seek mental health care or counseling and give patients resources within your community to do so that they have actionable steps to take to address that.
So where does prevention come into play here? And when does it have the most impact?
Absolutely. So prevention is a vital role in the conversation, not just in the prevention of FASDs, but largely in the prevention of negative birth outcomes associated with substance-exposed pregnancies. The easiest way to prevent a substance-exposed pregnancy is through universal screening and having frank, patient-centered conversations around substance use, pregnancy, and contraception. In one of the trainings I actually do with the CNM on our team, Lily Bastian, we discuss the importance of facilitating culturally safe conversations around these topics and also give strategies and scripts for nurses to talk about substance use, to talk about pregnancy, and talk about the contraception needs of patients on a patient-centered basis. So if you have more questions about that training, it's also accessible through AWHONN, as you know, and their website, and available for CE credit.
Those are some really great resources, Faith. Thank you. As we conclude, based on your research findings, what are the most critical evidence-based insights that you'd want every nurse to understand about alcohol and polysubstance use across the lifespan? And what does the research suggest as the highest impact practice changes nurses could implement in their own practice?
The first thing I encourage all practices to do is universal screening, right? The most important evidence-based insight would be to use the SBIRT system, which is screening, brief intervention, and referral to treatment, as it's an extremely important tool that all nursing professionals should be utilizing in their practices. It is inexpensive and reimbursable and takes just a few short minutes to complete. SBI has been proven to reduce excessive drinking in primary healthcare settings, but it's often underutilized or people feel uncomfortable implementing things like universal screening practices. But universal screening practices prevent things like bias or people from judging what they consider to be a substance user, right? Because we really don't know what that looks like. I would also add that it's important to provide FASD-informed care to patients with an FASD. Communication and support is extremely important to ensuring positive patient outcomes, and this looks like using patient-centered language, addressing autonomy, and making sure that you're co-creating plans that can work for your patients.
Thank you so much.
Yeah, absolutely. Thank you so much for having us today.
Thank you.
Every time your team is here, I learn so much information, and today is not any different. What I heard is that overcoming substance use disorder, it takes a comprehensive, patient-centered approach. It also takes insurance coverage and policies that fully cover the needs of those needing care for substance use disorder. It takes utilizing the universal screening tests that you all mentioned during our episode, and it simply takes healthcare professionals that care to allow people to exercise their autonomy. So Faith and Katie, I'm so glad that you could return to share your research results, because one of our AWHONN Insights goals is to not have one and done episodes. We know that the issues we highlight are complex, they're multi-layered, and they cross the lifespan. Dr. Cass and Shannon, thank you both for your thoughtful approach to this episode. I'm sure listeners, they now have more action items that they can implement in their care, especially with adolescents. For all of you listening, thank you. And we ask that you please go to awhonn.org/podcast so you can read Faith and Katie's full bios, and you can utilize the resources that they shared. It's going to be a number of them. You can also go back to our episode from last June in 2024 and click on the links so that you can access all of those resources from the previous team's research in Alaska. Thank you so much for your time. Please subscribe on YouTube, Apple, Spotify. Send us an email if you have questions about this episode, comments, or you have an idea. We thank you for listening. We appreciate your time. Please stay safe and be well.